Chest tube insertion by Concepcion Clarissa C. Materials needed: sterile gloves, sterile gauze, silk zero suture, cotton balls, vaselinized gauze, chest tube 28 to 32 F for adults, 10 to 28 F for children, drapes and towel clips, lidocaine and syringe, pickup forceps, povidone iodine, scalpel, plaster, iris scissors, curved Kelly forceps, and needle holder. Chest tube insertion or tube thoracostomy is the most common thoracic operative procedure. The indications to perform this are all types of pneumothoraxes, hemothorax, hemopneumothorax, hydrothorax, chylothorax, emphyema, subcutaneous emphysema, and pleural effusion. Step 1. Preparation of antiseptic. Soak the cotton balls in povidone iodine. Make sure to follow sterility protocols all throughout the procedure. Step 2. Preparation of local anesthetic. Reminder: anesthesia bottle is unsterile. Step 3. Preparing the patient. Position the patient in a semi-upright position with arm of the affected side above the head. Clean the skin surface with povidone iodine, making sure to cover a wide area of chest wall. Do this step 3 times. Reminder: start at the axillary line in the 4th or 5th intercostal space. Use circular strokes outwards. Step 4. Draping. Hold the sterile side of the drapes. Lay down the drapes first at the surgeon's side, then cephalad, followed by caudad, and lastly opposite the surgeon. Secure with towel clips. Step 5. Infiltration of local anesthesia. Palpate for the 5th or 4th intercostal space at the anterior axillary line. Position the syringe bevel up into the subcutaneous layer of the skin. Infiltrate the anesthetic in all directions to block all intercostal nerve branches. Reminder: do not forget to include the pleura. Step 6. Create an opening. Hold the scalpel in a pencil grip. Incise in a straight line at the 4th or 5th intercostal space, still at the anterior axillary line. Reminder: incision should be 2.5 to 3 centimeters. and as close as possible to the upper border of the rib to avoid hitting neurovascular structures at the lower border. Use Shelly forceps to separate the subcutaneous tissues. Use your gloved hand and Shelly forceps alternately to create a tract running posterior, superior, and medial into the paravertebral gutter. Further enlarge the opening of the pleura with a large Shelly forceps. Reminder: perform digital exploration to remove pleural adhesions while minimizing risk of lung injury. Step 7. Inserting the chest tube. Clamp the chest tube at the tip of the fenestrated end with a Shelly forceps so that the chest tube and Shelly forceps are parallel to each other. Clamp the tube with another Shelly forceps at the area without fenestration. If you expect fluids inside the pleural cavity, also clamp the distal end of the tube. Carefully insert the tube with the aid of the Shelly forceps inside the tract. If you meet resistance, remove the Shelly clamp and insert the tube further by rotating it inwards the tract. Reminder: make sure that all the holes are inside the thoracic cavity. Step 8. Secure the chest tube. Suture the tube into the skin starting at the side of the tube. Use Silk Zero suture. Reminder: loop the suture under the tube. Cut the needle and tie the two ends of the thread with a square knot. Make series of X's around the tube. Pull the loops proximally and secure with another square knot. Step 9. Chest tube drainage. Connect the chest tube to a water-sealed device. Do this process carefully to avoid iatrogenic injuries. Reminder: release the cross clamp that is on the chest tube only after the chest tube is connected to the drainage device. Step 10. Wound dressing. Wrap the tube with the vaselinized gauze and layer 2 gauze squares with slits in a 90-degree angle from each other to avoid slipping. Have the patient take an X-ray to ensure the correct placement of chest tubes. Credits to Clinical Skills and Radiopaedia. Link in the description. Thank you, and please subscribe to my channel.